My name's Dr. Emma Vardy and I'm a consultant geriatrician based up in Salford. I work at Salford Royal and I'm also the clinical dementia lead there, and I also have a regional role with the Greater Manchester Strategic Clinical Network. And today I'm going to be talking about a project we've been working on in Greater Manchester around a community delirium pathway. So to give you an overview of what I've been going to be talking about, I'm going to be giving you a background to the work that we've been doing, talk about the community delirium pathway itself, bring that into some context, showing how we've transformed across the system, transform pathways across the system, talk about the obvious impact that that COVID-19 has had on many aspects, but also how it's impacted on this particular project, and what next, what are the next steps. So in Greater Manchester, we have had devolution and we have the Greater Manchester Health and Social Care Partnership. And with regards to dementia, that led to a programme of work called Dementia United. And it started a few years ago, and there are various work streams, as you can see. And delirium is a work stream that got added a little later on in the programme, but has developed into a really integral part of the programme of work. At the start of this, we developed some Greater Manchester Delirium Standards, and these were developed with a variety of health and social care professionals and people living with dementia and their carers. And they include provision of information for people and how to prevent delirium, that those with a diagnosis would have an assessment, those 65 years and over or who had a diagnosis of dementia would have an assessment for delirium on admission to hospital, that every care organisation would have a standardised pathway for the assessment and management of delirium, that family carers would be provided with information and support to help them supporting their relative with delirium, to ensure that non-pharmacological measures were being used to manage delirium prior to use of any pharmacological measures, that diagnosis would be shared between transitions of care, and finally that there would be follow-up for people with delirium from a multidisciplinary team with the skills to make appropriate assessments. And we've also, from the very start, used data to really shape what we're doing. So this just shows the number of people admitted to various organisations across Greater Manchester over the last few years. And that's really helped us to, by comparing similarly sized organisations, to look at observed and expected numbers of admissions with delirium. So I've just highlighted here Salford, where I work, and you can see that year on year there's been an increased number of admissions, but also from local work that we've been doing, we know that this is the tip of the iceberg, that we're detecting a significant number of people with delirium, but there are still cases that are being missed. And I've just highlighted another area, Stockport, and use this data to present to health and social care professionals working in that area to help make the case for a focus on delirium in different localities. So we've really capitalised on World Delirium Awareness Day, which has been going for a few years now, and a number of organisations have held events, and we've held events which have been really well attended, and we've used those as a focus and a pivotal point to shape our work as we have gone along. So on one of our World Delirium Awareness Days, we agreed some priorities with those who were in attendance for work in Greater Manchester, one of these being the hospital pathway and development of a community pathway, and finally education for both staff and carers, particularly for people living with dementia. And this is a flowchart to the structured approach to delirium for Greater Manchester, and we've built on this as the programme has gone on. Two of the key aspects to our pathways have been the use of the 4AT, which I'm sure many of you will be familiar with. And the second is a structured approach to looking for the cause of delirium. So we've used the mnemonic Pinch Me, and I've listed each of those letters, and some of them we've just made sure that we haven't missed certain causes. So for example, pain, we would ensure that we've included a review for urinary retention, and eye, not just infection but also intracerebral causes. A further key aspect to the pathway has been the time management bundle, which was developed by Health Improvement Scotland, standing for triggers, investigation, management and engagement and explanation. And we've found that a really helpful framework to use. Some of our starting points were, we knew that another team in Ayrshire and Arran had developed a community delirium pathway and had seen team members speak around that. And they were very helpful in sharing some of what they had learned and the structure of the pathway that they had used. We also used, included people living with dementia who might have experienced delirium, and also carers for people with living with dementia who had experienced a delirium to help shape the work that we were doing. We involved professionals from a variety of disciplines, including both physical and mental health, as well as social care. And really the programme was fast-tracked as a result of the COVID-19 pandemic and the fact that delirium proved to be a key diagnosis in the context of COVID, and I'll talk a little bit more about that later. So the development of the Greater Manchester Community Delirium Toolkit really was fast-tracked because at the start of the COVID-19 pandemic, there was a lot of transformation around community services, and one of the particular key areas and a key reason for hospital admission is delirium. So developing robust, safe community pathways was identified quite early on. So some of the approvals from the perspective of Dementia United and the governance was fast-tracked so that we were in a position to pilot this. So we had already been engaging with a number of stakeholders, and the pathway had pretty much been finalised, but it was just some of those final aspects were fast-tracked just at the start of the pandemic. Our key aim was to increase detection and improve the outcomes for people with a delirium. Sorry, there's a missing word there, but you know what, you can see what I meant. Another key aspect is raising awareness using the single question in delirium, that community teams would use that as their first part of their assessment. We also developed an information leaflet that could be used in conjunction with the pathway for provision for carers or people who'd experienced delirium. And we had quite a sort of an ambitious remit, not just explaining what delirium is and explaining how that may or may not resolve in any follow-up needed, but also covering prevention and something specific around the cause in that particular individual. Another key aspect of the programme has been training, and we've used certain national resources that have been developed, for example, on how to use the 4AT, and there are some excellent resources developed by Yorkshire and Humber Strategic Clinical Network in conjunction with Health Education England that we've used. And the toolkit has a variety of documents within it. There is an overview with time frames. It includes various resources that might need to be used in conjunction with that, a guide to what blood tests might be required, what investigations would be required, and guidance, very practical guidance around management and engagement and explanation. And we've decided to pilot this so that there is room for any final improvements, adaptations. And we started piloting this in September of this year, 2020, and this will go through to January 2021. I'm just going to pick out a few key aspects of the pathway. So one of the elements is the time frame, which is very much in keeping with national and regional guidance. So that initial urgent assessment should be within 2 hours, which would include the 4AT and the initial part of the time bundle. And then over the next couple of days, further investigation management would be completed. We've included optional resources that would complement the pathway and might be required to complete the pathway, and also given guidance around any equipment that might be required and why. And there are links to these different resources on the Dementia United website with the toolkit. There's guidance around investigations, what urgent bloods might be required, and this has probably been one of the aspects that involved quite a bit of initial discussion with some of the teams, and teams liaising with primary care staff that they were also working with, because this might not have been a part of care offered, already established and offered through some of the community teams. And you can see there's further guidance around some of the other investigations that might be required and equipment that would be required. The Greater Manchester Delirium leaflet, developed by a trainee, Rachel Kirby, in conjunction with our Delirium steering group, and also with people living with dementia and their carers. And this also went to our regional carers dementia group that have been developed in conjunction with Tide Carers, to ensure that the wording was accessible, that it was understandable, it was serving the purpose that it was developed for. And just to draw out, there's an area on the back of the leaflet that includes being able to document the cause of that particular person's delirium and the date the diagnosis was made. And this was something that came from carers wanting to be, to understand around the delirium and what had caused it in their particular relative, and to empower carers. And also to be able to try and prevent a further episode of delirium happening in the future. For example, if the cause was constipation, then being able to proactively manage that such that would be prevented, and prevent precipitation of a further episode of delirium. How we engaged teams across Greater Manchester, well, we put out an expression of interest. We held launch meetings with individual teams. We're currently holding bi-weekly meetings. That's a real opportunity for teams to discuss things that are going well, things that have not gone so well. We have a Microsoft Teams channel for these teams. There is structured guidance to measurement to show and evaluate how the community toolkit is working and how it's being applied and how many people are on the community delirium pathway. And as I've said before, the pilot is running till spring 2021. So the bi-weekly drop-ins have been really insightful, really helpful for teams to share what's been going well, what hasn't, for us to look at any measures, share updates on outcomes, to learn from each other, to make some adaptations as we've gone along based on what's been practical, what's been found to be difficult or not working so well. It's an opportunity to ask the Dementia United team questions. Myself and one of the project managers, Helen Pratt, work together to host them. And it's also peer support for teams to each other who are testing the toolkit. And we also have a robust governance pathway in place, which includes a delirium steering group, which is multidisciplinary, and also includes carers. There's a Dementia United Implementation Operations Group. There are locality leads, and all this also feeds into our Dementia United Strategic Board. So we have several teams who are piloting this programme, and teams that are yet to pilot but have shown significant interest. So the teams who are currently actively piloting are in Trafford, Central Manchester, at Salford, where I am based, Bolton, Stockport, and Manchester Intermediate Care Service. We also have interest from Bury GP practices, and we're also initiating work with Salford Intermediate Care teams. And we also have links with Northwest Ambulance Service, who are particularly forging some robust links with our Trafford locality. How did things change with COVID-19? Well, pretty early on, us geriatricians realised that there was a link between delirium, that delirium may be a presentation of COVID-19, and there was some excellent work published around this. So this is the ISERIC study showing that confusion, altered consciousness ranked really near the top of reported symptoms. And this and other studies attracted media attention. There was a study published in Age and Aging by Zazara and Penfold around probable delirium as a presenting symptom of COVID-19 in frail older adults. It hit the news with the BBC, and working with colleagues from the British Geriatric Society, there was an opportunity to work in conjunction with Public Health England to ensure concise, accurate wording of the circumstances and the link between delirium, and that COVID testing should be considered in both older people and people with a cognitive impairment. So that was an excellent example of learning from what was happening, looking at published literature, and that really feeding into changing public health policy. We know as clinicians, I'm sure many of you will recognise this, the presentations of delirium in the context of COVID, and I won't go into great detail, but delirium being initial presentation, and I'm sure majority of colleagues would say any older person presenting with delirium at the present time during the pandemic should have a swab for COVID, but also seeing cases of terminal delirium in people already with a diagnosis of COVID-19, and both of these have presented challenges and of course distress for both staff and for patients and also their carers. I thought I would just also show you this. This is a further study published in Age and Aging around the outcomes for older people with COVID-19, showing that those with COVID-19 and delirium, this holds a particularly poor prognosis with a mortality rate of 72% in the presence of delirium compared to 32% without. So it's important to detect. And COVID-19, despite, the heartache and the awful situation that we found ourselves in, has also presented some opportunities for transformation in delirium care and for transformation in care in the context of delirium in Greater Manchester. We've capitalised on existing work around the use of digital and electronic health records. We had already completed a project at Salford Royal in the acute hospital in the emergency department setting, using the EPR to complete assessments and enhance diagnosis rates. To really enhance the need to detect and to screen for delirium. We've used data and presented and showed data to encourage change. There's been a real frailty agenda that has emerged, and of course people with frailty are more at risk of delirium, so there's been opportunity to, I guess, piggyback, if you like, raising awareness of delirium. There's been, as I've said before, a request for community pathways, particularly with development and evolution of hospital at home services. There's been real challenges in terms of relatives and restrictions to visiting, and also the isolation caused by care home visiting and links with delirium. There's been lots of discussion about how best to treat delirium, and particularly delirium in the context of COVID. And it's also stimulated discussion around some of the publications that we've seen, conversations around terminology and use of the term delirium. In Greater Manchester, it's opened up conversations in a variety of other areas. So some of whom are already involved in the Dementia United project, but also looking farther afield. So mental health teams linking in with frailty, end of life and dementia agendas. More recently, linking in with learning difficulties. We've connected up with the local ambulance service. There's also a project, something called Safer Steps, which has been led by Saf Ahmed and Martin Vernon at Thameside, which is looking for softer signs of deterioration in people in care homes, and the app includes new confusion. So again, that's been a gateway to enhance delirium detection and improve care and management. We've made links with public health. There have been developments locally and I know regionally in terms of a COVID virtual ward and ensuring that delirium detection is incorporated, and development of delirium is incorporated in those pathways. There's also conversations about if somebody has had a delirium and develops cognitive impairment as part of long COVID, and discussion around how those people would be followed up. And certainly locally, delirium has been highlighted in COVID-19 mortality reviews. And we've also been asked to do webinars both nationally and internationally, because there's a great deal of interest of enhancing care for delirium in the community. So what next? Well, first, our current pilot, completing that and ensuring we robustly evaluate it. So watch this space. We're continuing to work with partners, and it's been a bit of a series of opportunities in coming across new partners. We're planning on transforming our patient information leaflet into some different languages to meet the needs of our local communities here in Greater Manchester. And we're also planning on developing a hospital toolkit using very much the same principles as our community toolkit. So in summary, I would say a strong driver for some of this work has been data, collating and using what data you have, and also using data collection systems to reveal what the problems are. We've used a whole systems approach, which has resulted in connecting with a number of different organisations and professionals across the system. We've been encouraged, and I guess COVID-19 has really fast-tracked thinking outside of the hospital, and COVID-19 has developed, really put a spotlight on delirium. So we've been using the current momentum, and many of the resources that I've talked about are available in this web link at the Dementia United website, and we're continuously updating that with new resources. I must acknowledge various people who've been integral to this project. Helen Pratt in particular, who's a senior project manager with Dementia United, who I've worked very closely with, but also Lindsay Bailey, Emma Smith, and a number of other colleagues. Members of the Delirium Steering Group, a number of different individuals, too many to mention. Rachel Kirby, who is not on this list, but is a trainee who has recently, luckily for us, acquired a training post in geriatric medicine. And also thanks to Tom Jackson for a couple of the slides that I've included in this presentation. So thank you very much for listening. And if you're interested, please do get in touch. There are some contact details for myself and for Helen and Emma Smith, who are involved in working on this project with me. Thank you.